Hello, my name is Isaac Matthias. I am the co-director of the IM portion of the EM-IM Ultrasound Fellowship at Penn, and this is the start of our 2019-2020 Ultrasound Fellow Lecture Series. So we're going to start off today with Knobology. So this is the screen on our Mindray for picking our probe and preset type. At this point, this person is selecting the adult abdominal preset. And I put this slide up because selecting the correct preset, it really is going to take you 80% of the way to having perfect knobology when you're doing your ultrasound scans. So if you think knobology is too boring and you want to turn off this lecture right now, that's 80% just fine, as long as you remember to pick the correct preset for the organ that you're looking at. It's going to take you a pretty long way. And I see people over and over and over again neglecting to do that, especially new learners and people that have been accustomed to using ultrasound just for procedures and are not as used to using the ultrasound to look at diagnostic images to help with management. So we're going to come back all the way around to this at the very end of the talk, but if you don't make it there, that's probably, as I say, 80% fine. Just remember to pick the right preset for the right organ, especially if you're switching from organ to organ looking at within one patient. And that will pretty much take care of most of your knobology needs. Okay. But if you're like me, then the preset is not enough for you. You really are fired up to twiddle the knobs and make the picture look as absolutely fantastic as we can do it. And to make the knobs be the most good and fantastic that they can be, we have to recite the poem. And the poem goes: depth, gain, focal zone, frequency, dynamic range. If you are going to make ultrasound, at the bedside part of your practice, you're going to say this poem to yourself at the beginning of each scan, and it's going to get easier and easier to remember to look at each of these knob twiddling options and make the image look the best possible. So let's start looking at the aspects of the poem. And before we get into the individual parts, we can actually see that the machine is reciting the poem for us in the upper right-hand corner of the image. And this may be at a different spot on different manufacturers or different machines, and it might not always include all the fancy info that our Mindray is giving us here, but pretty much all point-of-care machines are going to have the knobology settings listed somewhere on the machine. So whatever machine you use, I really encourage you the next time you open it up to see where this is on the screen and see what kind of settings you can adjust. And I forgot to circle it in red, but up here further at the top of the screen it says adult ABD, and that is that preset that we had selected back here. So as I was saying before, the most important knob on the knobology may actually be the organ preset. So that is also going to be displayed on the screen. So getting back down into the poem, depth is our first option. So I'll go back here and we can see where the poem is recited on the machine. D for depth, G for gain. Focal zone actually is not listed in here, but it's this green caret on the machine. So focal zone is 6 centimeters. F for frequency. So here's F. Our frequency is harmonics 5 megahertz, which we'll get back to. As I said before, depth is 12 centimeters, gain's 49%. So depth, gain, focal zone, frequency, and dynamic range, DR, is 115 decibels. And there's some extra info in here that we're going to skip out on. So the first line of the poem, D, depth, in the image on screen left, I can tell you that the depth is too much. because this kidney is only about halfway down the image, and it's the organ that we're interested in looking at. Now I can look where the settings are listed and say the depth is set to 19 centimeters, or I could count that out, 15, 16, 17, 18, 19, all the way down here. Or I can, as I say, just look and say this is too much depth. The kidney on screen right is taking up about 80% of the depth available, leaving about maybe 20% of the far field screen with no kidney in it, so we can make sure there's no free fluid and pathology deep to the kidney. And this is really about the depth that you want to be working with. 80% of the image taken up by the organ of interest. And if you compare the image on screen right, say we're looking for little small objects such as the renal pyramids here, it's really a lot easier to make out their quality with the depth reduced sufficiently. On screen left, this little renal pyramid's just harder to see, and I would say that this depth setting it may seem obvious, but it's really the thing that's not going to be corrected for by using the appropriate preset. We see patients of all different types of body habituses, and in many places, including on our machines, the depth is set very deep because, on average, we have big patients with difficult body habitus. But when you get a patient with a more smaller cachectic body habitus, the tendency is to see this kidney here and just smash your face into the screen until you can see what you want to see. And that's a bad strategy. Really remembering to decrease the depth until our organ of interest is taking up 80% of the screen and looks nice and big and we can see what we want to see is going to be a huge help to your image interpretation. And a little bit surprisingly, this is the aspect of Knobology that I have the biggest complaint about with new learners and even people that are fairly experienced with ultrasound. When you're in a rush or when you're a new learner, it just really tends to be the case that you forget to adjust the depth, and to compensate for that, you really squint and bring your face really close to the machine and maybe barely can see what you want to see. But an optimized depth is going to really take you far, and is probably the knob that you're most needing to adjust and most likely to forget to adjust. So that's the depth. Let's move on now to zoom, which is sort of a subset of depth. And this is what the zoom icon looks like on our Mindray machine. We'll see it in action on the next slide. So screen left is a first trimester pregnancy with the uterus here and a gestational sac right here. Screen right is the same image but with the zoom on, and I know that because when I look in the bottom right corner of the screen, there is a zoom icon which shows the bit of the image that's actually been zoomed into. So you can see that on screen left, they've really appropriately adjusted the depth. The object of interest, this uterus and gestational sac, is overall taking up 80% of the screen. But when we're looking at small things like trying to identify a fetal pole with a fetal heartbeat and dealing with challenging anatomy, as we are here with a lot of adipose tissue, making the depth appropriate is often not quite enough. And that is because the machine is holding out a little bit on us on this image on screen left. It is taking a few pixels and condensing them into a single pixel and displaying that to our eyeballs on the screen. The image on screen right with the zoom really, zoomed in a lot, maxed out, the resolution is as high as it can possibly get. The machine is no longer taking multiple pixels and smooshing them together into a single pixel. So with that maxed out zoom, I can now make out that there is a fetal pole here with a flickering fetal heartbeat right there. You can see it flickering pretty easily. And on screen right, it's just not possible with the limit in the resolution and the smaller amount of the screen that their object of interest is taking up. So for really tiny objects, maxing out the zoom can be the difference between a diagnostic scan that we're seeing on screen right here and a non-diagnostic scan that we're seeing on screen left that would require the patient to get a transvaginal ultrasound to come up with the answer that all we had to do is take 10 seconds to turn the zoom on and get the answer on screen right here. All right, so on to the next line of our poem, gain, G. So depth, gain, here is G for gain. It's set to 45 on screen left and it's set to 8 on screen right. So gain on the MindRays is a number out of 100. I think on, sort of a percent. I think on machines that give you a little less control, like some of the Sono-sites and things like that, they may not actually give you a number for gain. They may just give you a wheel you can dial to the left or the right. But I don't get so hung up on this number. I care more that we're looking at fluid that is black. And that's exactly what we're seeing on screen right here with an appropriately gained image. And that's exactly what we are not seeing here on screen left with fluid that has a bunch of hyperechoic, white echoes inside of it. And that's sort of the standard, especially with abdominal imaging, that we adjust the gain by. We turn the sound down until the fluid is black. And on screen left, where the gain's too high, I can't see this bile duct. I really am not confident this is a bile duct. I would not measure this thing and, make a guess about whether the patient has biliary dilation or not, because this fluid, in this case the bile, is just being replaced by echoes. But when we crank the gain way down, make sure that all of our fluid, like our blood in our portal vein here and our bile in our bile duct, is anechoic and black. Now we can see the edges of the bile duct very crisply, and we can make an appropriate measurement for the diameter of the bile duct. So that is especially for new learners, how to think about gain. Turn the gain down until the fluid is black. That is not true in 100% of cases. For abdominal imaging, where we're oftentimes looking for fluid in the form of looking at a gallbladder, looking at a bile duct, looking at a urinary bladder, looking for free fluid like blood or ascites or anything like that, turning the gain down is essential so we can see the border between the fluid and the abdominal viscera. But there are cases where a higher gain is appropriate when we're more interested in looking at the parenchyma of things. That's especially true in cardiac echo ultrasound, where the turning up the gain really makes it easier to see the edge of the endocardium, but it's usually okay. The blood is still anechoic enough that it's to your advantage to turn up that gain to make the endocardium come out. So don't say fluid, anechoic, and black as a dogma, but it's a great starting place, especially for abdominal imaging. And beyond, from that, just remembering to look at the gain, crank it up a bit, crank it down a bit, see which makes the thing you're looking for come out better, is going to be to your advantage. Hugely important in putting in vascular access, I find. I don't have a reliable rule for whether to turn it up or down, but it can really either make the vessel pop out or the needle pop out. TGC is a subset of gain. It stands for time gain compensation, and this is just the gain at a different at certain levels or depths of the image. So in the image on screen left, this is my stomach that's full of a bunch of water that I drank, And deep to my stomach is a pancreas with various vessels going inside of it, like a splenic vein and an IVC there. But they're really hard to see because this pancreas and the vessels within it are super overgained. And that's because of the posterior acoustic enhancement behind this big fluid-filled stomach. And we'll hold off on getting into what posterior acoustic enhancement is today. That'll be for our next week's lecture or coming up lecture of artifacts. But we don't need to know all the physics of it to know that we want this gain to be lower. But we don't really need to lower the gain in the stomach or really even the abdominal wall. These fluid is black, the gain more proximally is more or less appropriate. So what we do is we turn down the TGCs, the time gain compensation, just in the far field here. And that's what's been done in the image on screen right. There's been no adjustment to the near field TGCs, but the far field TGCs have been turned down. And probably not enough, to be honest. I should probably remake this image. But now I can see that splenic vein and that IVC and the other vessels and even the parenchyma of the pancreas a good bit better than I could on the screen left image that's just way overgained. So, this is what the TGCs look like on our Mindray. There's sort of sliders that you can slide to the left or to the right. This is the near field TGC. This is the far field TGCs. So in our last image, the image on screen left would have had these sliders in the far field turns down, taken to the left over here. On machines like the Sonos they're not going to give you these sort of sonographer, ultrasound tech level sliders to play with, but there are near and far field gain adjustments, typically knobs, and they typically are just right below the overall field gain. So if the TGCs make you nervous, you're sort of an early stage learner, you can just ignore those near and far field gains and just adjust the overall gain, and that'll probably be more than fine to look at the thing you want to look at. But don't be afraid of if you just see a knob that says near gain or far gain. At least know what that is and know not to touch it if you don't want to adjust the gain in just the near field or just the far field. Just use the overall gain, which will usually be the topmost of the 3 dials on the Sonos. So this image is what happens when you forget to adjust your sliders that were seen in the last image. And I, in fact, took this picture just walking in at whenever it is I come in the morning and going up to our Mindray machine and just opening it up and taking a picture of what I saw. This is completely the rule, not the exception. Our bedside, clinician sonographers pretty much, unless they're me or part of my cadre of ultrasound maniacs, are always forgetting to reset the sliders, the TGCs, to the middle. And you should do that, on these fancy Mindray machines that have sliders for many depths of the field. Step one before you even select a preset or put the patient's name in is slide these back into the middle, and they'll make sort of a satisfying clunk type of sound when they lock into place right in the middle. If you forget to do that, you're going to put your probe down and try to look at a gallbladder, and this is what you're going to see. This sort of band of hyperechoic tissue at the far field of the image. And, I guess this is not completely disabling, but if there's a big stone here in the neck of the gallbladder, you may miss it because your TGCs, your gain in the far field has been turned up or forgotten to be adjusted and left too high and making this artifact type of band across the far field. So, reset these TGCs to the middle before you start scanning, and you won't have this challenging hyperechoic problem at the back of your image where all the things you want to look at are like your neck of your gallbladder and your portal vein with bile duct somewhere in here and so forth. Okay, so we're moving along the poem. We've gone on to the line that goes focal zone. So what did we do? We did depth, we did gain, and now onto focal zone. So focal zone, as I said, is not listed on the Mindrays in the settings listing, but it's represented as this green caret on the side of the screen. Many machines, especially Sonos do not give you access to this focal zone. They basically set the focal zone at the mid-level of whatever your depth has been adjusted to. So if you don't have access to a focal zone, don't worry about it. It's not so critical. If you do, it can really help your image. So we're looking at the right portal vein and the hepatic artery and bile duct that are branches that are running along with it. And on screen right, the caret has been set for focal zone to be right at the level of this portal vein. And we can make out these tiny little structures, these hepatic artery and perhaps portal vein running along with it. On screen left, I've purposely put the focal zone at 2 centimeters, much too shallow, and it looks a bit mushier down here. I'm having a harder time identifying these tiny little tube structures of the hepatic artery and the portal vein, and there's just more artifact and distortion within the portal vein as compared to this really nice, crisply outlined portal vein here. The physics of what a focal zone does, I will just touch on extremely briefly here. When you are making and I'll just mention it because I think it helps to remember what it is and bother to even adjust it. When you're sending out a beam of sound from the ultrasound to come down and view this portal vein here, it's really not just a laser-like beam of sound coming from one transducer element. All of the beams of sound get created by a lot of transducer elements. It tends to be about half of the total transducer elements in the machine or in the probe, and centered on the element that's making the sound beam that's displayed on the screen. And they make a sound beam by converging on the midline of the sound beam that's shooting down. And if we set the focal zone at the near field, somewhere up here, like we see on this screen right, we're going to see sound beams coming in at really high angles, sort of like I'm drawing with the cursor here. And if we set the focal zone at a deeper depth, the sound beams are going to be coming out at much smaller angles to converge at the midline here. So that's how the machine does it. Maybe that was a little bit boring and unnecessary, but it helps me remember how, what a focal zone is, or bother to adjust it. Because if all my sound beams are pointed up here, but my object of interest is down here, you can imagine that the sound beam is not so crisp and narrow and skinny as we want it at this level of depth where my object of interest is. Okay, we're moving along to the next line of the poem, which is frequency. So we can say depth, gain, focal zone, and now frequency. I faked myself out here. This is actually frame rate FR, which we'll talk about a little bit later, but it's not in the poem. Frequency, however, is, and it's denoted by this F here. And the story that you've probably heard about frequency is that lower frequency penetrates better. It goes through the tissues without getting attenuated so much, but it is a lower resolution. Typically, we want the highest frequency we can get away with without having the sound get attenuated too much. In this case, we're actually finding that the image is a little bit nicer with a lower frequency here on screen right. And that's because I'm interested in this IVC right here. And on screen left with this higher frequency here, this 2.3 to 5.7 megahertz range frequency, it's pretty difficult to really make a call about the volume status of that IVC, because this is a patient with a decent amount of adipose tissue, but even worse, a really steatotic liver. We're not doing a good job of showing that steatotic liver here, but just trust me, this is a super steatotic liver, really attenuating our sound beams. When I drop down the frequency to this lower range here, now I can pretty clearly make out that the IVC is round like a basketball, and I'm a little bit more happy about giving that nice dose of IV Lasix. So typically higher frequency, better picture, but you have to understand the exception is when we're having difficulty seeing deeper structures in obese patients or steatotic livers or other things. Turning down that frequency to a lower frequency is going to help us see our object of interest in the far field. The way that I got these frequencies to be what they are is by going to the frequency button and shuffling between gen, pen, and res. Even on our fancy Mindray machines, that's what the frequencies are called, just like they are on the Sonos. So gen is for general, it's the medium range frequency. Res is for resolution, it's the higher range frequency, and I think that's what I've used here to make it hard to see our IVC. And pen is for penetration, this lower frequency range. The difference between the Sonos and machines that don't give you quite as much information and the Mindrays, which give you more information, is the Mindrays actually tell you what the frequency range is that corresponds to that gen, pen, and res. But for new learners or people that don't like to make themselves anxious by looking at these numbers and letters in the upper right-hand corner of the screen, I want you to feel comfortable and confident knowing that pen is the lowest frequency, res is the highest frequency, gen is the middle, and adjusting those, as needed to make your picture look the best possible. Typically, you may find that the preset for this, abdominal preset here is set to gen, but if we have a really cachectic skinny patient, you might as well drop it to, decrease or increase the frequency up to that res frequency and really get your super shallow gallbladder. You can imagine a really cachectic patient with a gallbladder all the way up here. You'd be better off at that higher res frequency. Harmonics is a subset of frequency, and the image on screen left has no harmonics, and the image on screen right is using harmonics. And I know that because on screen right, for that fake out, there's a letter H next to the frequency number, denoting harmonics is on. We do not see that H on screen left, so there's no harmonics. The other thing that looks a little funny is that on screen left, on these fancy Mindrays, we get that frequency range denoted, but on screen right, where the harmonics are on, it just gives us one number for frequency, 5.0. So what's that about? Well, let's come back around to that in a second. First of all, what do we see here? We see a not so great image on screen left, and we see a really awesome looking image here on screen right. So far, the thing I know about harmonics is that they're awesome and they make the image look totally awesome. And specifically, I see a liver where the resolution of the speckle, the little white, black, and gray is much higher than this smushy, schmeary looking image with no harmonics. I think I'm going to have a much easier time making a call about the quality of this liver parenchyma. Is it heterogeneous or is it nice and appropriately smooth? And how about this gallbladder that I want to look at? Here I see a nice, gallbladder with no echoes in it, really easy to see how thick the wall is. It's a little bit thick because I think I had eaten recently. You can see all this bowel gas and the collapsed gallbladder is making the wall look a little thick. Here on screen left, with no harmonics, my gallbladder is full of echoes. I can barely make out where the edge of the wall is happening. It's way less crisp. So yeah, no harmonics, terrible image. Why should you even listen to what I'm about to drone on about for the next, hopefully not that long? I think that understanding how the harmonics works, like all of these knobs, if you understand the basics of how it works, it's going to help you remember to use them or turn them off more at the appropriate time. So I think it is worthwhile. So how does the harmonics work? I'll make this as quick and sort of simplified as possible, but both of these images, the transducer is sending out the exact same sound frequency range. This one, it actually tells you the frequency. This one with the harmonics, for some reason, it's just giving one number, 5.0. But I can tell you for a fact that this, even though it says 5.0 here, this transducer sent out the exact same frequency range, that 1.9 to 4.6 frequency range that the no harmonics transducer sent out. But the difference between these two images is that on screen left, the ultrasound machine listens for all of the sound that comes back to it like it always does. So that sound's going to be in this frequency range, and it's going to have a maximum frequency somewhere in between these two. The harmonics image ignores like all of this sound range, and it only listens for 5.0 megahertz sounds, which are twice the frequency of the central frequency of this sound range. It doesn't work out to the middle number average between these two, but just go with me and accept that the central frequency of this frequency range is 2.5 megahertz. So that 5 megahertz is the second harmonic. 2.5 megahertz is the first harmonic. Don't worry about that too much, but it's sort of like, if you're playing the piano going up an octave from the note that you're playing. Hopefully, I don't know that much about music, but hopefully that's an accurate comparison if there's any physicists listening to this talk. So what that does by only listening to the double the central frequency that's been sent out, it makes the image much more crisp, much more high resolution, and much less echo free, or much less, artifact free in things like fluid. Why? Well, basically, to generate a harmonic, to have that 2.5 central frequency sound hit some tissue here, like a little bit of liver here, or a little bit of edge of gallbladder wall here, and generate a harmonic, a double frequency to come back, the sound has to be pretty strong. And only the sound at the center of the sound beam is strong enough to generate a harmonic. As we were talking about a little bit in the the focal zone slide a few slides ago, the real sound beam made by this ultrasound is not just a laser beam of sound that's coming directly straight down from the probe. It's actually generated by a lot of elements shooting sounds in all at a sort of a midline point, and that ends up making a fairly wide kind of sound beam. But only the very center of that sound beam is strong enough to generate a harmonic, a double frequency to come back. So really, when you only listen for that harmonic, it makes, in effect, the sound that comes back a lot more of a skinnier type of beam, a lot more laser-like. And without getting into the details, this artifact junk in here in the no harmonics, gallbladder is not strong enough to make a harmonic. So all of that junky artifact filling up our gallbladder gets taken away when we're only listening for the harmonic coming back. So that is a little big bit of an oversimplification, but it's already getting boring and we got to move on. But that's why it just says 5.0, because it's only listening to that second harmonic, and that's why the H is on, and that's why the image looks nice. So if you want to take a step back and look at the big picture, you would say no harmonics, bad image; harmonics, awesome image; harmonics equals awesome. I'll always use harmonics. And that gets to be fairly true with cardiac and abdominal imaging. But there are some cases where it's actually a good idea to turn off the harmonics. And I'll get to that in this slide, and I think this is going to justify a little bit this tedious physics junk I've been going into for the last few minutes here. So this slide has to do with the disadvantages of harmonics. And there are two basic disadvantages of harmonics. The first one is that it basically takes two harmonics images to generate one ultrasound picture. And because of that, the frame rate, FR right here, is 17 in the harmonics image, and it's double that, it's 34 frame rate in the no harmonics image. That is something that doesn't really come into play in reality at all, because I can tell you that the main type of ultrasound imaging where we get hung up on the frame rate is cardiac imaging, where we want to really see a lot of pictures of the heart squeezing so we can make a good, accurate estimate of the LVEF and valve motion and things like that. And I can tell you that cardiac echo is done almost exclusively with the harmonics on, so they don't even bother to turn the harmonics off. They may have done some other things to try to jack the frame rate up that we're not going to go into right now, but that's more of just a curiosity that the frame rate's going to be double when you turn the harmonics off. The thing that affects reality is that there is a disadvantage to using harmonics, which is it decreases the penetration of your ultrasound. So as we remember, both the harmonics image here and the no harmonics image here are sending out the exact same frequency range, central frequency, sound pulse. So they're at the same frequency. That doesn't seem like the penetration should be affected. But the harmonics over here is only listening to that first harmonic, which is double the frequency of the sound, the central sound frequency that was sent out. So in effect, the sound coming back is a much higher frequency, really a double frequency. And that higher frequency sound is going to attenuate a lot more quickly, and therefore your overall penetration when the harmonics is on is going to be decreased. And most of the time that's not enough to make a big problem, but in patients who are having a challenging body habitus, a steatotic liver, again I'm looking at steatotic liver patients, that can create problems. And here with the harmonics on, I'm trying to take a look at the IVC, and I'm not so confident. I mean, I guess I can see it's round, but it's I'd be a little nervous to just bet my life that this patient's volume overloaded. And I definitely am having a hard time seeing back here the aorta. That just looks like a bunch of random pixels moving around. Over here on screen right, I've turned the harmonics off, and it's easier to see this IVC, and I can definitely believe that this thing is an aorta. So when you're having challenges, penetrating deep enough in a patient with a lot of adipose tissue, steatotic liver, etc., turning the harmonics off is an option. Now, it's going to make your resolution, especially in the near field, worse. But that may be, here I can, with the harmonics, I can even see some probably hepatic vein there. But if all you care about is seeing the IVC, then who cares what the resolution of this junk is up here, especially when you can't even see it anyway because, the patient's such a challenging habitus. Okay, so moving on, I guess, to the last line of our poem, dynamic range. So depth, gain, focal zone, frequency, and at long last, dynamic range. So this is another one where I'm going to get a little bit into the physics. It may be a little boring, but I think there really is a payoff to understanding the basics of what dynamic range is, because it is really going to affect your understanding of the cases when adjusting the dynamic range is going to make a difference. And it's actually really important to conceptualizing why selecting the right preset is probably the most important thing we can do in Knobology. So if you're listening to this slide at this point, or if you just believed what I said in the first slide, that selecting the right preset is important, you'll basically get the equal outcome where you select the right preset. So dynamic range has to do with the range of echo intensities that the machine is compressing and displaying on the screen. So what do I mean by compressing? Well, the human vision has a grayscale color depth of about 1,000 shades of gray, which is equal to 30 decibels. 30 decibels is equal to 3 bells. Bell is basically just a order of magnitude, exponent of 10. So 30 decibels is 3 bells, is 10 to the third is 1,000. So a normal human can more or less see 1,000 shades of gray. A normal ultrasound machine, a modern day fancy ultrasound machine, has a range of echo intensities that it can detect of 200 decibels, or 10 to the 20th. So 10 to the 20th is a bigger number by a lot than 1,000. In fact, it's bigger. You can just multiply it by 10 to the 17th. That's how much bigger it is than the human vision grayscale color depth. So how are we going to take all this crazy 10 to the 20th amount of possible shades of machine vision and compress it down into the 1,000 shades of gray that the human eye can see? And in fact, the machine uses only 256 shades of gray. Well, that's going to have to do with what dynamic range is and compression curves, which are kind of a synonym for dynamic range. So here are two dynamic range compression curves. The curve on the left is 150 decibels, and the curve on the right is 100 decibels. I can see this curve goes from 50 decibels to 150 decibels. The difference between those two is 100. So this is a 100 decibel dynamic range curve. This is a 150 decibel dynamic range curve. And the bigger dynamic range curve is going to include a bigger spectrum of sound intensities in the scale, the shades of gray that are displayed on the screen here in the y-axis. The 100 decibel dynamic range curve, it's more compressed. It's going to exclude more sort of sound intensities from what actually ends up getting displayed on the screen. So for the first 50 decibels of sound that the machine hears, from anything below 0 it can't hear, up to 50 decibels of sound, or 100,000, 10 to the fifth, 100,000 times stronger than the very softest sound it can hear. All of those are just going to be assigned to a grayscale of 0. They're just going to appear anechoic and black. But on this higher decibel number dynamic range curve, those excluded anechoic echoes here are actually going to get assigned a shade of gray here. So the simplest way to put this all together is that the bigger number of decibels in your dynamic range, the more shades of gray you're going to get on the screen. So let's see what that looks like in reality. So the image in the top left of the screen has a dynamic range of 115 decibels. And this is sort of the factory settings dynamic range that comes with this abdominal preset. And this is pretty much a nice looking abdominal image of a liver with a little bit more hyperechoic pancreas here, with some anechoic splenic vein and SMA and IVC. And this is pretty much an optimal dynamic range number and curve for what we're trying to view here. So what would happen if we turned this dynamic range down quite a bit? Well, the answer is that things would get a lot more black and white, because things that used to be softer sounds, quieter sounds that used to still be given a grayscale value, they're just going to look, anechoic now. And in fact, when we turn the dynamic range down from 115 all the way down to 50, that's exactly what we see. We see that the vessels like the splenic vein and the IVC are just completely anechoic and black, whereas they did still have some echoes over here, and that has something to do with, I guess I'd left the gain a little too high. But anyway, really crank that dynamic range down, they're just black. And now this fat that surrounds the SMA is just completely white. It's a grayscale value of 256, totally echoic. Compare that to the higher dynamic range curve, where it's it's more echoic than the things around it, but it still has some gray to it. And down here at the bottom of the image is just the opposite. We've taken the dynamic range from the factory settings of 115 and cranked it way up to 200. And now everything looks just a bit more gray and schmooshed out. Fluid-filled vessels are even a bit grayer. The fat is even a bit less anechoic because there's just so many shades of gray to choose from. So far, this dynamic range business seems to be kind of a waste. The machine factory settings have an appropriate dynamic range. When we turn it down or we turn it up, it just makes the image look bad. It makes it hard for us to identify the structures we want to see. So why would we ever even want to learn about dynamic range? The answer that I use in my practice pretty often is that it is another trick that can help us identify vessels and fluid-filled things. So here is the image on screen left, and I want to see this IVC, and I want to make a choice about whether or not to diurese this person. But I'm not really happy with this image. This might be the IVC, it might not, it might be full, it might not. I can not really see much of an edge of a vessel wall, opposing liver parenchyma. Dynamic range 110, right at that factory setting for the abdominal preset on our machine. Now on screen right, exact same patient, exact same abdominal preset. I've turned the dynamic range down, not too dramatically, but turn it down to 85, whereas it was 110 before. And now it's much easier to see this IVC, and you can even see the hepatic veins that are engorged and trying to drain into the IVC here. So turning down that dynamic range, we're going to lose some information about the liver parenchyma, and its shades of gray, but we don't really care about that. All we really care about is knowing what's fluid and what isn't, what's IVC and what's not IVC, and therefore how distended is the IVC. And now I feel much more confident with this big IVC and big hepatic veins by turning down the dynamic range that it's Lasix time. That's an interesting case, but one that comes up not so often. I mean, we have enough patients with challenging body habitus that it's a good knobology skill to have, but it's really only less than half of the story of dynamic range. So this is another one. This is the end of the talk, so try to hang with me for this boring physics stuff, because I think it actually paradoxically is the most interesting and most important slide of the whole talk. So these are two different compression curves, but they have the exact same dynamic range. This one is assigning grayscale values to dynamic range of decibels from 0 to 100, making it, a machine will show 100 up here in the dynamic range spot. And here is a curve where that runs from grayscales assigned to 50 decibels of loudness up to 150 decibels of loudness. So 150 minus 50 is once again 100, exact same as this compression curve on the left. So both of these compression curves, if you were to look at our fancy mind ray that gives you an actual number for dynamic range, the dynamic range number is going to say 100. But the images are absolutely not going to look the same. The curve on the left, you're going to see a lot of echoes that are, of less intensity, quieter sound. Get assigned some grayscale numbers, get assigned some gray pixels. But really high intensity, loud sounds, are all just going to be whited out, snowstormed out. You're not going to be able to distinguish between something has a loud sound intensity and something with an even louder sound intensity. On screen right, we're ignoring everything in the low dynamic range setting. So maybe if this is the edge of if this is liver parenchyma and this is wall of portal vein, you're not going to really see anything. You're just going to see grayscale of 0, anechoic black. But things that have a higher intensity, like muscle and fat and things like that, are going to be better defined. So how does this relate to reality? Well, this is sort of comes back around and meets at the middle or meets in the other side. This is what's actually happening when you're selecting your presets for your machine. Selecting the EM abdominal preset, it does have a preset, frequency and whether or not the harmonics are on, and even a preset depth and a gain and all that. And on our fancy mind ray, we can adjust all these things. But we absolutely cannot adjust what compression curve the machine is using. So here we have an abdominal preset where the curve is more along the lines of the one on the screen left here. The lower intensity echoes are prioritized. And we see a nice looking liver with a really detailed parenchyma that I can make a comment about. No cirrhosis here, no increased heterogeneous echo texture. On screen right, we have the cardiac preset. This person was looking at the heart, and then they just picked the probe up and put it down on the liver and IVC and started looking down here. And even though the dynamic range is exactly the same, dynamic range 110 here, dynamic range 110 on screen left, the image really looks different. This liver parenchyma looks much more salt and pepper, more black and white, as compared to this smoother, better defined liver parenchyma on screen left. And that's because this cardiac preset is using this higher shifted sort of compression curve. This is not something that you can fix by messing with the dynamic range. You cannot say, oh, darn it, I forgot to switch my preset, but that's such a pain. I've really got my probe in a good spot, and I like how I'm pointed at the IVC. I think I'll just adjust the dynamic range and make this liver parenchyma look appropriate. That will not work because you cannot change the sort of general distribution, the general of the curve. And this gets a lot more complicated in how the engineers program these things. But this is I would say right up there with images that have too much depth for things that drive me the craziest, and things that new learners or even fairly experienced bedside sonographers mess up and don't understand why their image looks bad. Many times the learner comes to me and says, I've been trying to look at this heart. I'm sure this patient has a good window, but this just does not look right. And I look at their image and I say, well, that's because you've got the abdominal preset selected. The heart is just never going to be well displayed, no matter what you do with the patient or this position of the probe or the other knob positions. So understanding what a dynamic range curve is, I think, is really nice to have a basic understanding of, so that you can understand why it's so important to select the correct preset for the organ that you're looking at. And I've been going on and on about this dynamic range number that we have on our fancy mind rays, but you can adjust the dynamic range on machines like the Sonosite that don't give you specifics of how many decibels your dynamic range is. On a Sonosite, it might not be displayed in the settings area, but it will start with a dynamic range of 0, and you can crank it up to +3 or down to -3, and that will have the same effect as on our fancy mind ray machine of turning the dynamic range number to a lower decibel number.